Iqbal. I'm working as a consultant obstetrician and gynecologist at Hamid Latif Hospital, Lahore. I welcome you all to the webinar on ART and gynecological laparoscopic surgery. As you all know, despite being the 5th most populous country in the world, we still have a prevalence of 21.9% of subfertility, out of which primary is like 4% and secondary is around 18%. Subfertility is important not only in the context of its physical entity, but as a social media too. It can have serious implications on physiological, physical, psychological, economic, and social well-being for the couple. Laparoscopy has a major role in both the workup and management of gynecological causes leading to subfertility. So we will be discussing a bit of hysteroscopy and recent advances in ART and some management of PCOS. Just a comment here, if you have any questions, you can add your questions in the chat box and they'll be answered by the faculty as we go on. Before we move on, let me introduce you to the chief guest of today. The name needs no introduction. However, just to give us a reminder, Professor Dr. Latif Khan, he's Professor Emeritus of Obs and Gynecology. He's the pioneer of ART program in the region and established the first IVF center ever in Pakistan in 1984. He was the founder president of SAFOG, past president of SOGP, and the founder president IVF Society of Pakistan. Among the many feathers in his cap, he also has Sitara Imtiaz by Government of Pakistan. He's the visiting consultant at Lahore Institute of Infertility and Endocrinology. He's the chairman, executive committee, Raj Latif Medical College. So to begin the webinar, our first talk is by Professor Yusuf Latif Khan. He'll be talking to us about the role of hysteroscopy in ART. Let me introduce him before he starts. So Professor Dr. Yusuf Latif Khan is the Program Director, Endoscopic Courses by Minimally Invasive Gynecological Surgery Unit, which we call MIXU. He is the Clinical Director, Hamid Latif Hospital, Lahore. He is Professor OBGYN at Raj Latif Medical College, Lahore, Pakistan, IVF Consultant at Life, and Secretary General at SAFOG. He's also the General Secretary, Founder Member of Society of Gynecological Endoscopy, SGE. So over to you, sir.
Okay. Thank you very much, Mariam. And first of all, I would like to, let me put it, just hold a second, I can just, okay. Okay. So welcome everybody. So first of all, I would like to thank the KZ Pharma for kind of organizing this seminar in these kind of difficult times. And I think a lot of things going to change about after this COVID epidemic. Hopefully whenever it's going to be over. Lekin jab tak ye khatam nahi hota hai, when it doesn't finish, we still have we can't just stop educational activities at the moment. So with this, the show must go on. And it's the people of pharma like these KZ ones who kind of promoting all these educational activities, which I'm sure kind of benefit to all the participants who are going to take part in this. As Mariam mentioned that laparoscopy, hysteroscopy, they have to be work kind of hand in hand with the infertility part. And I don't think so, okay, any infertility setup can benefit or can be complete without the help or assistance without laparoscopy or hysteroscopy, because as the time goes on, they're becoming one of the gold standards in the management and workup for an infertile couple. So all of you, I'm sure all the gynecologists sitting here, they've been doing DNCs from the day one. As like me, this was one of the first procedures in gynecology which was imparted to us and was given a chance to perform that. And I suppose that was way back in 1998. From that point of view, it has come a long way, and you do understand that doing a DNC is the easiest and as well as most difficult part as well in any gynecological procedures, because it is done blindly. And anything which is done blindly, you do understand it is associated with complications and, of course, not the complete completion of this procedure. So I'm going to just give you an overview of the histoscopy and why it is important. And I'm sure by the end of this, you should do realize that anybody who works in either gynecology or with this associated with the infertility needs to have this thing done. So these are the different places where we have our fun. Fun means that these are the places where we get up in the morning and we rush to our working place because we do enjoy our work. And this is not only for me, this includes all the team members who kind of work with us. Because of this thought process, we normally are supportive to each other, and this, as a result of all this, it all benefit in the end comes to the patient. So this is our Hamid Latif new tower, which is over there. This is the Life Center, which is right next to Hamid Latif. And this is our medical college, Rashid Latif Medical School. And that's a 600-bed charity hospital, RF Mobile Teaching Hospital, where we all of us come and do work with us. So one of the things which I always admire is this favorite slide of mine here is the vision, which I personally think anybody who's doing any kind of procedure, if it is done under vision, it becomes more easier, it becomes more effective, and it gives much, much more benefit to the patients as compared to anything else. So you can see this bright red apple around here and a couple of oranges around here. From the outside, they look very nice, perfect, but you never know when you open them up. It has been seen once you open them up how disastrous this thing is. And once you open up an orange, you never find out there's an apple inside. The day which we start off with my team of Mixu is that I do get a call in the early in the morning. He said, these are the patients which are on the list today, and one, two, three, four, and whatever. And this first one, this patient, this is a very simple one with a simple cyst or simple fibroids of not a big size. And I think we should start doing that. And these are the ones who kind of are difficult ones. So we'll do this in the later on hours. And invariably, those we anticipate to be difficult surgery, they turn out to be pretty easier. And in those we think that's kind of a simple one. And sometimes we do end up having these kind of problems in which we don't know where we are and the problem continues. So here the vision comes in, but the prediction, okay, this patient, as all of you will see, that it's not possible to judge the book by the cover. So it's the same thing. You can't judge a patient by just the look of it. But yes, you can anticipate, but unless until you go in with the camera or with the laparoscopy, you figure it out, okay, how difficult or how easy that is. These are a couple of things. Those are people who are kind of my age would know what this sign kind of represents. Those who are younger than us probably would not have seen this one. And these are a couple of other gadgets which you can see, which are no more available. Yeah, you don't able to see that around. It's just in this now in your society these days. I do remember having these floppy disks working with. They had I think a couple of MB uh, uh, hard drive or storage space into them. But now the terabyte is not an issue, and I think we are moving on from terabyte to whatever I think gigabytes and whatnot going forward. So these are all the things which I'll come back later on this thing. So getting a knowledge from anything is basic is to you need to kind of read about it. And to read about this, we do have available these guidelines available, which are very simple to read around, small booklet, but they do make your vision, they do make your thought process, and very easy. And do remember all those complications which they have written in their booklets, they will be there and they will come out, and you might have to face them. Allah na kare more frequently, but sometimes as you move on, they will do appear in itself. So this is one of the guidelines, which is number 59, as you can see, and it's for the best practice in outpatient histoscopy. Why I've put this up, because as the easier it gets, the gadgets they become easier, the process has become simpler, the patients they tolerate it much more easier. So from the theater anesthesia, they move down to this office part, which is as simple as doing it in the operation theater. I'm not sure we can do the diagnostic part, that is okay. But the operative part in our setup is kind of slightly just difficult, but we still, in our group, managed to do this still in the theaters, not in the outpatient as such. But we do plan to make this kind of in the future. This. So to evaluate anything in the uterus, can you see that this is a four-dimensional ultrasound in which you can see there's this uterus, endometrium, the lining, and whatnot. So this is the simplest non-invasive thing. But the unfortunate part is that, can you see this part? That is very important. That's the endometrial cavity inside. So we can see the endometrium, but we cannot figure out if there is something wrong inside this. So to see that, it has to be distended. So once you need to kind of distend that, the you will not be able to see small polyps or fibroids or any other foreign body inside them. This is the other way in which we can do routinely done, and in which it's a hysterosalpingograph in which dye is inserted through the vaginal cervical cannula, and you can see the cavity around here. These are the tubes. This is the cavity around. These are the tubes coming in, and you can see the spillage from one side to the side. The advantage of doing this is that if there is a polyp or fibroid inside the uterine cavity, you can see this is small arcuate kind of small septum around in the fundus, but I don't think so that's kind of interfere with your fertility or subfertility. So that's another method of viewing the inside of the uterine cavity for any blockage. But this is kind of a gold standard for those patients who does not have any kind of history and you think everything's fine. But do remember that HSG is done in one of the, if I ask my participants sitting here, normally done in the what do you call it, X-ray department, in an X-ray room, where they don't have any kind of concept of sterilization, and the doctor who goes with them is the junior most house surgeon, and the person who's holding the tray is the ayah of the hospital. So once you go there, you don't take care of this sterilization process. As a result, what happens is that if the patient isn't having any PID, there's a very good chance doing that in those exit department where there's all the technicians are standing around is only possible that causes the tubes to get blocked and she ends up having a PID and whatnot. And if she had an open tubes, there might be chance you might kind of blocking that. So you're not kind of benefiting these patients, but you kind of that. Yes, if you plan to have this setup in your private setup or in a government setup, then you need to have a very specialized trained SOPs for doing this hysterosalpingography wherever you think it can be done. So now coming back to histro, this is kind of an histro which we do. You can see this is a cervical canal. We going in. This is a non-edited kind of video. And as you can see, to going to the cervical canal, that's the hole where you want to move in, because that's the internal os. And once you go through the internal os, the cavity opens up, pops up. There you can see this. This flipping part is the endometrium. That's the fundus down there. If you move your pointer to one side, you can see one os here. And as you move the other side, in a moment, you will see the other os here. So there you go, that's the other ostia coming in. And this probably is done by one of my consultants who work with us, because it hardly takes about not more than, if it is done go smoothly, 30 seconds or maybe 40 seconds for routine. And that is one of the reasons that in all the infertile cases, we invariably do this hysteroscopy before imparting on any of the procedures. And for those patients who are even going for myomectomy or for endometriosis, we do look at inside the uterine cavity. So one of the most common things which we get referred patients from the life center is the polyp. When they do the ultrasounds or TBS, they find out there's a polyp inside the uterine cavity. And of course, if there is a polyp inside the uterine cavity, you can't proceed with an IVF, or you have to get them removed or see what happens. So the prevalence is something like between 8 to 35%, and symptoms, majority of them, about 68%, they do present with abnormal bleeding, but they are patients who don't have any kind of symptoms. And if it is less than 1 centimeter, we do give them about 1 cycle or 2 cycle break. So to sometimes when they uh, menstruate, they just kind of dislodge in their periods. But if it persists for about 1 cycle or after 2 cycles, then we do advise them to go for a hysteroscopy. And of course, there's you can't differentiate between a polyp, endometrial polyp, or myoma inside the uterine cavity. For that, you have to do this, what you call that, hysteroscopy. So while doing this hysteroscopy, of course, in the same sitting, we kind of removed it by either using the forceps, if it's a fibroid, by using a resectoscope. And again, if you have, luckily we do have this myoshow or true clear, or what we call that shaver, that can be used, with, which causes, do the morcellation with that, and easier for these kind of bigger size polyps or fibroids to be removed. And position is the same simple one, in which patients is put in the standard dorsal lithotomy position, and we prefer to give it general anesthesia if it's a small procedure. Normally, it's done under mask, and if it's kind of a, you think it's going to take longer time, in which you require to have shaving or use of resectoscopes, then probably intubation with general anesthesia with the tube is a better option. Doing it internationally, they do it in the local paracervical blocks, but we only prefer to do it if there is some kind of what we call that, contraindication of any kind of anesthesia, and it's kind of a simple procedure. Then we can do it in the local or paracervical block as well. But the position in that would be, of course, remain the same. So here you can see, if we go in, that's in the middle cavity, which I was showing you there. And there's this polyp, it's a pedunculated polyp. And with the help of the scissors, which goes through the hysteroscope as well, we're just going to cut the base. And once the base is out, as a result of this, it can be easily pulled out. While doing a DNC, there's a good chance, I think, if I'm not wrong, about 30 to 40% chances you're going to either miss this polyp altogether, or you take it out, but you don't take it out completely. So this is another one, in which the previous one we were using the scissors. Again, that's the uterine cavity. Can you see that inside? And once we go in, there you can see this again, small polyp is less than 1 centimeter, is kind of showing on the way, and we go back to make sure we identify where both the osteas are. This is one on one side again, and that's on the other side. So we can see that by the rest of the cavity looks all right. That's the thickened endometrium down there, and that's the polyp over here with the pedicle here. So this is a simple grasper going through that, and you just grasp the uh, neck of this polyp down there, and you just pull it away. There you can see, you can kind of grasping and taking it out, making sure whole of it is out. And as a result of that, once it is out, you just kind of remove it. It's the hysteroscope which we use is about 2.8 French. So it's a very, very small, and normally, in majority of the cases, we don't have to kind of dilate the cervix at all with this. Yes, we do give misoprostol before this procedure, which makes the cervix soft and easier for our procedure. So, in this one of these cases, we could have used the scissors, but I think in these ones, unfortunately, our scissors got broken or was not available at that time. What we probably oh, here it comes. Sorry. So now they've given us scissors, so it's easier to kind of just cut it. And once we cut this out, and you can see That's the wall of the uterus, and that's the polyp down there. And once it comes out, and we are all good and set. And of course, with the grasper, then you take it out. The reason why it is not bleeding is that because when you distend it, you do it with some pressures, which are normally more than 100, and as a result, then they don't bleed at all. And even if they do, once we close it, the uterus is a muscular organ. Once it contracts, we will be all right. So normally, what we do postoperatively, don't do anything. We just normally, if there is small bleeding, it should stop on its own. And we tell them if they are going for an IVF, it takes about 2 months or maybe 3 months to make sure the endometrium is kind of healed properly so that they can do the embryo transfer. Complications, yes, as I said in a DNC, of course, if it's a big size, it's an incomplete removal, but if you cut the base of it and even leave this polyp inside, they'll kind of necrose and can be expelled out. But it is usually is done in those cases in which there's a fibroid. With this endometrium, they're so soft they can easily be taken out from the cervix. Yes, you can do the cervical dilatation, but do remember that the more you dilate the cervix, the more chances of this the patient might have the cervical incontinence in the future whenever she becomes pregnant. And of course, if you're not very careful, there's a possibility of uterine perforation. And that is why whenever you go in for the hysteroscope, you need to identify where the osteas are to make sure you are in the uterine cavity. This is one of my again favorite videos. Here you can see this is Maradona. Unfortunately, he passed away recently. One of my favorite football players. Why I want to show this video? You know, he's kind of warming up for a match. You can see next to all these people, they are kind of running around. But this person is only focused on the ball. And you can see the laces, they are open. He doesn't care. He and the ball, they are kind of one. So once they are together, he can do whatever he wants to do, and the ball is under his control. He is not under the control of the ball. All of these things, all of these things, they do come only with one thing. That is hard work and practice. It doesn't come overnight. They all, it only comes in with hard work and efforts, which all must be do. So he is not being controlled by the ball is controlled by him. And these hysteroscopies and laparoscopies, they are all also kind of a skill in which you have to put in a lot of effort and time, and then you become that. So next common thing which we do come across for infertility as well as for other things is the septum, and they are about 5% in the normal anomalies, and most of them normally they don't require to have luckily any kind of treatment for so, but some of them which are they do require that, and you can differentiate between a septate uterus and arcuate and biconjugate. And it's by definition, if the arcuate is less than 1 centimeter, biconjugate is more than 1 centimeter. Normally, biconjugate uterus, they are the one who requires to have some kind of a surgery to make sure the cavity is fine, because now they've been associated not even for only for preterm labor, but for early first trimester miscarriages also. Um, of course, before you go in, you need to have a good ultrasound for you, so make sure it is there. You don't do a procedure unnecessarily, but do remember that unless until you go in with a hysteroscope, that is the best diagnostic as well as operator tool for these kind of things. And you can cut this septum either with the help of scissors, either with the loop like electric cautery for monopolar or bipolar as well. So this is one of the videos in which you can see that's even in the cavity, that's one of the ostia, and that's one of the cavities around here, and there's a septum around here, and there's another ostia and this up here. So this is small kind of test. This patient, she had an history of about 3 miscarriages. So we planned to do that. On ultrasound, she was okay. And once we did that, this is again the small scissors, and we just kind of cut the septum. Luckily with the septum, the advantage is that because it is fibrosis, normally it does not bleed. And this scissor is very small, but as you kind of cutting it, you can feel the cavity also opening up. And this cavity opening up kind of reduces the chances for the patient to have a preterm labor or the first trimester miscarriages. But don't do this unnecessary, especially in those patients who had previous normal deliveries or term pregnancies, because every procedure is associated with some kind of what you call that complications. And one of these complications for this septum section is because you have to make sure, okay, you know where you're cutting from, because if you cut more, then there's a good chance you can kind of perforate this with the scissors. And if you cut less, there's kindly chances that you're going to leave some septum unattended. So this is another one, as you can see, two cavities, one on this side and the other one on this side, and that's the septum down here. And this again with the cutting with the scissors, it's an easier one. As you come, the both cavities they become one. Do that. The objective while doing that is to bring both the osteas as in a straight line. As a result of that, then the cavity is kind of a norm. But again, making sure you don't overdo it or sometimes when we are not very sure okay, how much to cut, we do use another laparoscope. And while doing a laparoscope, we put in a port to make sure that we are away from the fundus and as much as is required. So all these points has to be considered to the patient before you go in for this kind of surgeries or movements. So this is again a septum, but this time we're using this electric surgery. You can see this, that's the septum down there, and it's kind of an hook, which using this either bipolar energy. Initially we had this mono one, but this is a bipolar one, as you can see, it can cut. This is more beneficial to those one in which the septum is too thick. So the chances for this advantage of using these kind of instrument over here is that they coagulate any part which is kind of leading to small vessels can be coagulated with the help of this thing. And as you go in, you kind of these are again, I think, one of our earlier videos. So now what they don't generally guide is that you don't start from the end where we are right now and go to the back. You start from the back and come back towards yourself, which reduces the chances for any kind of perforation or complication associated with this. Of course, once you have used up so much of energy, there is a possibility of adhesion formation. So for that, there are a couple of things which we can do. One is this, we can put in a gel, which is available in the form of high berry in the uterine cavity, which prevents any kind of adhesion forming between these two. Or for temporary putting in a small catheter, beads, uterine catheter, जो बच्चों में आप यूरिन के लिए कैसे डालते हैं, सबसे smallest size. You put them in the cavity once it is all done, and you inflate it about what 3 ml or so. As a result, the cavity will kind of remain distended for some time, making sure you do have this good antibiotic cover. You can take it out later on. We normally do that after about 48 hours or so. And these guys of videos we've done so much of electric cautery and do that. We normally repeat the histoscope again after about 3 months to making sure that there are no adhesion formation or anything else. Here you can see the ostia coming close down there. So we're kind of reaching up to that point, and still we have some septum left on this side. So we're kind of cutting it up. And while doing these extensive kind of septum resection, we do put in a port laparoscopically, making sure we don't kind of perforate the uterus. And number two, uh, if you perforate it with the help of a scissors, normally because it's a so small size, we don't have to do anything. But if we do perforate with this electric cautery, there's a possibility if there's any kind of injury to the intestine or anything which is very close to the uterus. So that is the trouble. Then the patient can present with some kind of intestinal problems later on. So again, that's the ostia. We come very close to that. So that's I think probably from this side will be done. The other side we will kind of do it again. This side we're going to cut because it was a tubular son, so we kind of move on to the next one. Of course, after doing that, we can use progestogens before that. That makes this what you call these septums or these lesions softer and easier to perform histoscopy in cutting them. And of course, as I said, to reduce the blood loss, we can use the dilated vasopressin. So what it does two things: it stops the bleeding, and number two, it generally because the vessels are kind of constricted. So one of the pitfalls with this using histoscope and these cutting this is that fluid overload. So once these vessels they are kind of constricted, the fluid will not kind of go in and it will kind of move on. Sure. Moving on, the complication, of course, the bleeding, which normally settles down on its own, either I said a balloon catheter or simple tamponade, or there's a possibility of 5 to 20%, something like that, of adhesion formation, which you can repeat it after 3 months, then do the scissors with that. The next one is these myomas, which are coming inside the cavity, and do that. For that, we use uh, the sectoscope. Here you can see this fibroid is here, and that's the base down there, and that's the uterine wall inside. And so that's you're trying to localize the base of this fibroid if possible. So as we move on, so this is a resectoscope. This you can see the chunk, and it peels this thing off like if you're peeling a there you can. It's cutting with a bipolar forceps, and it cuts small chunks. And as you chuck along, all this fibroid is kind of removed. But the cutoff for these fibroids normally is about 3 centimeter or so. And sometimes we have to do a resurgery inside. And in some cases, when the fibroid is too big, it can't be taken out to the cervix. We kind of leave it inside and tell the patient she might have some dysmenorrhea associated with this. And all those chunks are so small, sometimes they are expelled by this uterus, provided you give them good antibiotic cover so that the endometrium and the patient does not end up having endometriosis. This was unfortunately unmarried girl. This is what we call as vaginoscopy because she was unmarried, but she had severe and what you call as dysmenorrhea as well as heavy menstrual bleeding. So that's a cervix. We haven't put anything tenaculum or hold the cervix. It's with the head of the hysteroscope. We just kind of going in, and once we go in, here you can see that's one fibroid in the cavity. That's another one down here. There's a third one over here, and so on and so on. So this is kind of seeking fibroid all in the uterine cavity. So what we did, she had to be done the procedure in about 2 or 3 sittings. Initially, we tried to cut these fibroids with the help of scissors. Later on, we figured it out it's going to take a lot of time and energy. So we kind of abandoned this with the scissors. Then we used this the sectoscope, and after using the settle, all of these were cut, but she had to go through this procedure twice. But luckily now she became her bleeding kind of settled, and she was kind of saved of not going through her laparoscopy. Uh, Asherman syndrome, yes, they do come again, and that's one of the most difficult and part to do that. And because of the tuberculosis, especially in Pakistan, it is a very high incidence in those patients with that. And of course, in patients who had a previous history of DNCs, and once you do excessive curettage, it results in that. Maria, please let me know when the time is about to finish, please. And the symptoms, yes, menstrual disturbances, and one of the most common is amenorrhea. And there's also can be if there's outflow obstruction, then of course cyclical pain, recurrent pregnancy loss.
So we're going
Once you
to
classify them into minimal, moderate, and severe, I think minimum and moderate ones they're the easier one to kind of manage. Severe ones they are very unfortunate. They have to go through multiple procedures, and their outcome and success regarding fertility is unfortunately very poor. But these minimal and moderate, they perform, they respond very well. So pre-operatively, we do give them estrogens for 3 months, and as a result of that, we give them estrogens for 3 months continuously. It makes these regions very soft and easy to cut with these all kind of thing. There you can see one of our cases in which here we went in. She was the one who had her DNC done in some periphery, and result you can see these are kind of adhesions cavity may. These are simple scissors. With the help of the scissors, we try to kind of cut this, and there you can see a band. It looks like a septum, but it's not a septum because once it opens up, you can see from posteriorly it is all open. So with the help of scissors, you can see, and the cavity kinds of opens up. Unfortunately, she had multiple fibroids also as we went in. So we did her myomectomy as well, and with this, and then the tubes were patent, and we then referred her for an IUI. This is a more severe case of Escherman in which you can see actually nothing. These are only just white bands, and you're just cutting it with the scissors. And they are the cases in which there is a possibility of perforation, very high possibility of perforation. So for this, you need to have a good team, because while you're doing it, it's just a team which tells you when to stop, because of course you want to do the best for the patient and you want to do it in one sitting, but normally it doesn't happen. So here you can see, you can't see any kind of endometrium. You're just cutting it bit by bit, making sure the cavity as it enlarges. In this case, uh, she also had to have a procedure about 3 months, because after this we put her on estrogens, and then we were not expecting initially for that. And after that, we again did that, made the cavity. Here you can see the cavity has given a reasonable amount, but still it wasn't good enough for the fertility part. In the second sitting, it did, but unfortunately, she's one of those patients, as I said, because stage 4, they normally don't conceive so much. And even if they do, the chances of increta, percreta in these such cases, it rises a lot. So you need to be careful about that. So, as I said, the complication associated with this is perforation, repeated surgeries, and post-operative, as I said, pregnancy related, and of course, adhesion again formation and mid-trimester mod and placenta. Whenever I talk about this training of this cystoscopy and laparoscopy, what really happens is that once I talk to them, they say they are the seniors of them, they don't allow them to kind of work on it, or they don't allow that. But here you can see this a goat or maybe a PG having a confrontation with his seniors, but it's not this thing. They are trying his level best to make sure to that, and trying to convince his seniors that I want to do this, I want to learn this, and there's not limit to that. And if you have patience enough and persistent enough, I'm sure फिर वो कहते हैं कि जी अल्लाह मियाँ भी काइंड ऑफ उसमें बरकत डालता है, and finally the victory is yours if you are patient. So this is another one in which when we go in for laparoscopy and cystoscopy, the tubes are totally fine, but the dye doesn't come in. So this is a small catheter in which we put it through the cystoscope through one of the osteas, and as a result of that, these are the same things which we use in the. Here you can see the catheter coming out through this. This is the same which used for DJ stunting in ureters. So it's almost the same size. So we take out, you can see this catheter, how beautifully it is going back. And then we put in a dye, and you can see the dye coming in. And these are the patients who initially had to go for an IVF, but they have not chance to make sure that their tubes are patent. One of the most difficult or nightmares, I would say, for us is the adenomyosin. Those patients, when you figure it out on ultrasound, they say it's a fibroid. Once you go in, you figure it out. You can see this is not a normal endometrium. And there you can see a small patch over here. So what we did, we thought, okay, let's take a biopsy to make sure it's not something which is kind of a cancer or anything else. So with a small thing, we have this grasper. We kind of there you can see in a moment This gas is going to come in, and there you can see this endomyotic fluid or blood. It all comes out. That's another interesting case which we did. This was also an unmarried girl, a very young girl who came to us with severe kind of dysmenorrhea. First, when we thought that there must be something wrong, or ultrasound, we couldn't find anything else. So we thought there's two osteas, and that's the septum. But I was thinking, why would the septum causes so much of pain in this patient? So we kind of were looking around to find out what is the cause of this severe kind of dysmenorrhea and whatnot. So then, as we kind of looking and discussing between each other, we saw this flutter or something brownish thing coming out. And we thought, oh, wow, where is this coming in? Where is this thing coming in? So we kind of looking at it for a while, and that's the advantage of being working in a team. So you have a lot of suggestions coming in from all your colleagues and doing that. So we are not still sure what is wrong with that. Unfortunately, we didn't have this MRI done for this patient because of the affordability issues. So we waited, and then suddenly, as we kind of trying to focus, I thought, why it is getting bigger and bigger, and it's kind of not moving around.
So we're going a little
So
forward for the
what
time.
actually it was that in a moment you can see this thing coming out from somewhere down in the here. So it was non-communicating small, another second hole. So there was a small hole which, because of this hysteroscopic pressures, it kind of gave way, and this is all clotted blood in that septum. So once that was removed, we just detached the other septum with this one by cutting with the scissors. They became one cavity, and her pain kind of relieved. Because of tuberculosis, sometimes once you go in again, it's not one of the best videos. Once we go in, there is small these calcifications, as you can see. These calcifications, they are sometimes be seen in exposed patient in who had DNCs done, and small tissues kind of remain for the baby, and these bones can do that. So we go back in again and again, take this thing out, and if the cavity is complete, they are kind of into that. This is a patient who had 3 times some DNC done, and her still the RPCs were still inside. So this time we decided to do it hysteroscopically, and once we did that, there you can see, because that's the pregnancy, there you can see it growing, and the bag. This is on one side, and there was a septum on this side. So every time she had a DNC, the people were trying to do it with the other hole. But this time we did identify where it was, and then we removed this pregnancy part and advised her to come back after about 3 months. So after that, we did the septum section as well. So to learn any skill, you at least need to have 10,000 hours to invest yourself. That is a this very good book of outliers by Malcolm Gladwell. It's available online, free. If you don't have time, it's a beautiful read. So you will understand how much effort, how much time you need to put in to grasp any kind of a skill or improve on your skill which you already have. So for you, before we go away, this is a small video. Just concentrate on the video, which So my, I would say, suggestion to everybody is that please don't be dinosaurs like this. Be an eagle. You can spread your wings, fly, and the sky is the limit. And as we go along, and if you have a dream team like me, then everything works perfectly in certainly whatever you want to do. And this is another one of those things where you can see how these people are kind of work and making sure things come back to whatever you want to do. So that's kind of my dream team sitting here, of course, by the guidance of Professor Rashid Latif to be there. Fauzia, Sumbar, Mariam, also part of the moderator, Aruba, Rabia, and there's a theatre staff, and we all kind of work together. A couple of anesthetists I can see in this as well. So without them, of course, you cannot be. So my only take-home message to that is you can do it if you honestly put your heart and soul to it. So again, thank you for your patient hearing, listening, and stay safe during this difficult times. And hopefully there will be a time soon when we can meet each other face to face. And but do remember that life will go on. Thank you, and over to Mariam, please.
Thank you so much, sir, for a very elaborate discussion on hysteroscopy with live examples. There are a few questions that we'll discuss at the end of the session for you. Or next, so could you stop sharing your screen so I can log on? So our next speaker is Dr. Harun Latif Khan. Yeah, so he's a clinical embryologist, sexual medicine consultant. He's the chief executive of Life Pakistan, director Hamid Latif Hospital. He's done his master's in clinical embryology from Monash, Melbourne, Australia. He's also a fellow of sexual medicine, fellow European Committee of Sexual Medicine, and he is the founding member of Pakistan Society of Andrology and Sexual Medicine. He is also the General Secretary of IVF Society of Pakistan and the board member of Aspire. He's also my classmate, and I can't believe I'm introducing him in any of the forums, but here it goes. He'll be speaking to us about recent advances in ART. So over to you, Harun.
Thank you, Mariam. Thank you for your kind introduction. Can everyone see my screen?
Yes, we can.
Yeah. I'm having a little problem going full screen on it, so I'm gonna just do like this. I hope this works. Is this okay?
Yeah.
Yeah. So thank you, Casey, for arranging this seminar. One good thing that came out of COVID is that we've gotten so much used to doing these Zoom calls, Zoom meetings, and Skype meetings that it almost feels normal to be actually doing this. And like Dr. Yusuf said, that life must go on. It's been a year now since the world has been in it, and we need to move forward. We need to adapt to the new normal, and we need to communicate and keep on learning as well. Good thing about these webinars are they're less expensive. You can present from the comfort of your home, like I'm doing right now, and definitely end of the day the message goes across, and that learning definitely happens. So वो सारी formalities जो पहले हमें करनी पड़ती थी वो नहीं करनी पड़ती. Unfortunately, I don't have many exciting videos in my presentation like Yusuf did, but I'll try to finish this up within 30 minutes and just touch on some of the recent advances in assisted reproductive techniques. As we all know that ART is an evolving technique and new things do come up every now and then. So one has to keep up to dated and keep on reading and looking for new things, new techniques that are coming up both on the clinical side of the ART and as well as for on the lab side. So I'm going to touch both sides discussing some of the recent events that has taken place in ART. Just to put things in perspective, globally around 70 million couples are affected by subfertility or infertility, and access to or interest in ART has tremendously grown over the years. Obviously, the first IVF baby was born back in 1978, Louise Brown. She's 40 plus now. She's conceived naturally thrice now, and she has three lovely children. So since then, millions and millions of babies have been born globally through techniques which come under the banner of ART. The technology has evolved over the last 4 decades. However, with all this development and everything, still half of the couples who seek an ART treatment cycle remain childless. So we still have a extremely long way to go to address these problems. Like I mentioned, 1 in 6 couples worldwide experience some form of infertility issue. That's a big number, and I've taken this from ASHRAE, and this is from 2014. Another ASHRAE information from ASHRAE fact sheet is about 8 million babies have been born worldwide through ART. There are about 2.5 million ART cycles per year, and about 500,000 babies are born every year globally, and only 70% of all ART cycles globally are registered. So we're still missing out on about 30% of the data. So, like I said, it's big business now. In US and Canada alone, there are about 200,000 cycles. In Europe, there are about 600,000 cycles, and then Asia Pacific, there are about 330,000 cycles. In fact, in Asia Pacific, there are probably more than 330,000 cycles, because a lot of data is not coming out of China. And China is a country जहाँ पे it is said that दुनिया में सबसे ज़्यादा ART cycles हो रहे. So what is a target of an ART cycle or of an ART clinic? Obviously to maximize the benefit, which is live, healthy birth, and obviously minimize complications, which are cycle cancellation for the patient, ovarian hyperstimulation syndrome, and still a common complication happens in about 1.5 to 2% of the patients undergoing ART, and then of course multiple pregnancies. Although multiple pregnancies ka in Pakistan ये situation है कि almost every patient that comes to our clinic for an IVF treatment cycle, they want to have twins. Not realizing कि twins की एक अपनी complications होती हैं और अपने issues और concerns होते हैं, but they still want to have twins. और so इधर तो by choice होती है, but अगर globally देखा जाए तो obviously even in some of the countries in Europe, almost all of Europe, and some of the other countries across the globe, more than one embryo transfer is banned. So they only encourage SET, which is a single embryo transfer, which is the gold standard now or best practice now. So what are the services that we provide in an ART clinic, starting from basic workup of subfertility, ART counseling, which is one of the most important parts of an ART clinic. As we all know, that the success rate of IVF ICSI are limited around 40 to 45% at best. Hence, counseling of patients is extremely important and integral part of the services that you provide. Then there are other services like IUI, IVF, ICSI, freezing, cryopreservation services of both oocyte, sperm, and as well as embryos. And then there are some sperm retrieval techniques and other specialized tests which are done on the sperms. Besides these common services, some other services are now also coming under the banner of ART. Obviously, pre-implantation genetic testing is one of them, which definitely is a part of ART, is becoming routine, and I'm going to touch on it later on in more detail. Then there is endometrial receptivity analysis. I'm also going to touch on this a little bit more. It's called ERA as well. Then there is CGT, carrier genetic testing, which is basically testing a couple before they are planning a child, especially in those couples who have a family history of genetic diseases or genetic disorders. And for instance, some of the common diseases as well, such as thalassemia. And then there is non-invasive analysis for chromosomal examination, NACE, which is also commonly known as harmony test, which generally obstetricians and gynecologists are now routinely prescribing to their patients. They're kind of also coming under the banner of the services provided by ART clinics. We have come a long way. The first picture is of Bob Edward back in 1950s when he started work in IVF or in ART, and it took him about 25 to 28 years to get the first birth, Louise Brown, in 1978. So a lot of work went into that first birth when ART became a global phenomena back in 1978, 79. Of course, the birth of Dolly by cloning was big news back in 1996. And now in future, obviously, we're talking about longevity, we talk about slowing the aging process, and we're talking about immortality as well, which a lot of work is being done on that through stem cell therapies and through therapies related to it. So obviously, we don't know what future holds for us, but it's exciting times are coming, definitely, for sure. So some of the recent advances, you could say that there had been advances in the workup of subfertility or infertility. There've been improvement in drugs. There've been improvement in laboratory procedures, and obviously a lot of research and development is going on in the field of ART. Coming to the workup of subfertility, let's talk about the semen parameters a bit. Many ART labs do not employ the methods that meet the minimum standard criteria of World Health Organization or by ASHRAE-SIG group. So the problem with semen analysis right now is, especially more so in developing countries like Pakistan, that there's high uncertainty in reporting. Semen analysis reporting is very, very subjective. So even within the clinic, अगर आप दो endocrinologist को कहें कि वो report करें, तो at times बहुत फर्क reporting आती है. So it becomes extremely subjective and extremely difficult for the consultant to make a decision on the basis of those reports. So accurate reporting is extremely important, especially when semen analysis is concerned, क्योंकि उसी की base पे you plan the treatment for the couple. So it's very important. There are now tools available जो कि इस subjective reporting को change करके ज़्यादा automated और computerized कर सकता है. There's computer aided semen analysis available. We call it CASA. I think it is being widely used now globally, and it should be used in Pakistan as well. This would definitely reduce the human error part of doing semen analysis and would help in providing an accurate report so that the consultant can make the correct decision going forward. Then over and above basic semen analysis, there are some other specialized tests which can be performed on semen. One of them, which is commonly used now, at least in our clinic, is the sperm DNA integrity test. The sperm DNA integrity test is basically a test in which if the semen parameters are normal, you perform this test to see whether the DNA fragmentation rate of that particular sample is within the normal range or not. The normal range is that any sample which is considered to be normal should have less than 25% DNA fragmentation rate. If the DNA fragmentation rate of the spermatozoa is more than 25% and less than 50%, then it's a moderate report. And if the DNA fragmentation report is higher than 50%, then definitely it's a poor report in which natural conception may not be possible. So this is extremely important. Even with the normal semen parameters, if the fragmentation rate is higher than a certain value, then naturally conceived patient nahi karega. And at times in couples with unexplained infertility or subfertility, this is an excellent tool to have. और जब आप रन करते हो रिपोर्ट, एक्चुअली द कॉज ऑफ सबफर्टिलिटी सामने आ जाती है. तो वो जो 20% ऑफ द कपल्स हैं जिनकी कोई रीज़न सामने नहीं आ रही, either they're unexplained, and there are other also indications for this, such as recurrent pregnancy loss is one of the causes, sperm could be one of the causes, and some other causes are there in which we can use this test. It's a simple test. The husband only has to give a semen sample. It only takes about 2 hours to run the test. Same day reporting ho jati hai, and the cost of test is around 8 to 10,000 rupees. So this is something which all of us should include in our routine practice, especially for those couples who either have unexplained subfertility or who have failed IUI cycle. We prescribe this to our patients जिनका एक IUI cycle fail हो जाता है. And then thirdly, who have had recurrent pregnancy loss. अभी मैं chat पे देख भी रहा था कि recurrent pregnancy loss का कोई question आया था. This is also a tool you can use in those cases. Now coming to ultrasonography, obviously all monitoring in ART is done through transvaginal ultrasounds. However, things have moved on from simple transvaginal ultrasounds to 3D Doppler and even 4D scans. Why? Because you're not only using the ultrasound just to see the size of the follicle. इसमें सिर्फ ये नहीं कि आपने follicle size measure किया, एक certain level पे पहुंच गए 18 mm or plus, and that's it. The role of ultrasound is done. It's not like that. Evaluating the endometrium is extremely important. Now, within the endometrium, you just not only measure the thickness of the endometrium. We are doing a study in our clinic right now. उसका we hopefully will publish it sometime mid next year के अंदर, जिसमें we are seeing कि जिन patients के अंदर triple line होती है, उनके results हम compare कर रहे हैं जिनमें diffuse endometrium होती है but thickness is fine. So thickness उनकी आपको 7 mm से plus मिल रही है but triple line नहीं है. उनके अंदर implantation rate after going through an IVF cycle or embryo transfer is lesser as compared to patients who have defined triple line. So the role of ultrasound is extremely important, and if you're using 3D Doppler or 4D ultrasound, then definitely it would help you in making better clinical decisions. Obviously, hormones has a role. We routinely use FSH, LH, and progesterone as fertility predictors. AMH has been around for quite some time and is also a good tool to use it. However, AMH ka advantages to hai कि it's a glycoprotein hormone. It is expressed and also reflects in both pre and early follicular activity. It decreases with ovarian with increasing ovarian age, and it is a good predictor for ovarian response. However, you cannot use only AMH for this. जब initially AMH आया था तो उस पे बहुत ढोल भी बजा, and everyone's like, you only have to do AMH now. Role of FSH is out and all of that. But in our practice, what we have seen is कि आप तीनों चीज़ों को देखें, जिसमें आपकी antral follicle count है, जिसमें आपके FSH levels हैं, and then of course AMH. I still consider AMH to be a good predictor, but we cannot only depend on AMH. We should use the other two tools as well. Then obviously the trend has changed regarding the stimulation protocols. इसके अंदर obviously we need to improve the efficacy, better pregnancy rate, and improve the safety, which is less complications. Globally now, antagonist protocol or short protocol is being used. Obviously, it is much more convenient to the patient. इसमें number of visits to the clinic are less. इसमें the stimulation only lasts for about 10 to 12 days. Number of injections are less. So much more convenient. और बहुत बड़ा इसका एक advantage ये है कि there is a reduced risk of OHSS. It is also cost effective. So again, this is the gold standard now. Long protocol की value जो हम day 21 से start करते थे वो काफ़ी हद तक कम होती जा रही है, और most of the clinics have 100% switched to this short protocol. Coming to the ART lab, obviously it has to be a state-of-the-art facility. If you want to get good results, you can't really cut corners. These are the pictures of our lab in Life Clinic. We keep on improving the lab every few months. A lot of maintenance work is done during the months, and we keep on adding new equipment and discarding older equipment and all of that, because this is extremely important if you want to get good results. So I've picked three techniques, basically novel techniques for embryo selection, which are becoming actually a fairly routine matter now as far as ART is concerned. In तीन techniques में एक pre-implantation genetic testing है, and then there are two non-invasive techniques, which one is time-lapse imaging and the other one is metabolomics. Pre-implantation genetic testing, इसको previously PGD भी कहते थे, PGS भी कहते थे, but उन्होंने वो सारी terminologies को एक करके अब pre-implantation genetic testing कर दिया है. So this PGD technique can be done on 3 stages. आप उस साइट पे भी कर सकते हैं जिसमें पोलो बॉडी बायोप्सी करते हैं. First polar body, which only gives you the maternal genome, and then the second polar body after fertilization, which is extruded. You can also take both the maternal and the paternal genome. The biopsy can also be done at on day 3 post-fertilization, which is 6 to 8 cell stage of the embryo, in which you can take 1 or 2 blastomeres. And obviously now, generally speaking, it is encouraged to do the biopsy only on day 5 or day 6 when you have the blastocyst, and this is called the trophectoderm biopsy, or trophectoderm cells are taken. About 5 to 10 cells are taken. And then either you take the polar bodies or the blastomeres or trophectoderms. You can run them using different techniques, such as either PCR or FISH or gene array. And now the gold standard is NGS, which is next generation sequencing. The purpose of PGT क्या है कि आपने embryos को screen करके जो genetically normal healthy embryo है सिर्फ उसको ट्रांसफर करना है. उसके आपको 2 एडवांटेजेस हैं. एक एडवांटेज ये है कि in genetically normal healthy embryos the implantation rate is much higher as compared to if you transfer a non-tested or an aneuploid embryo. So implantation rate, hence your pregnancy rate, is also much higher, and hence live birth healthy baby rate is also much higher. So even some of the centers now encourage, and there have been studies as well that have come out जो encourage करती हैं कि to the extent कि almost कि सब patients के सारे embryos को PGT screening से गुजार के transfer करना चाहिए, and we'll have much better results. Like I said, there are 3 types of pre-implantation genetic testing which are available. One is PGT-A, which is aneuploidy screening, formerly known as PGS, in which the test determines whether the correct number of chromosomes are present in an embryo or not. The second one is PGT-M, which is for single gene defects, single gene disorders, such as cystic fibrosis, BRCA1 and 2 genes, and Huntington disease. And then the third one is for the structural rearrangements called the PGT-SR, which is screening of chromosomes, chromosome rearrangements like chromosome inversions and translocations. So all these come under the banner of PGT, but these are all 3 different techniques. Depending on the need of the patient, we can perform them. Large number of indications are there for PGT. Like I said, recurrent pregnancy loss is one of them. Unsuccessful ART cycle is one of them. Unexplained infertility, male factor, inherited diseases, so on and so forth. And as far as advanced maternal age is concerned, an interesting fact is that the percentage of embryos with an abnormal number of chromosomes. अच्छा हमारा ख्याल है कि with age obviously aneuploidy increase करती है, which is absolutely correct, but we have seen that even at a young age of 30, almost 1/3 of the embryos will be aneuploid, will have some abnormality. So that's a big number. And as the age increases, at 35, about 40% plus are aneuploid. At 40, 65%, and after that, it goes as high as 80%. So aneuploidy rate is even there in younger patients, and hence that is the reason कि मैं पहले कह रहा था कि PGT तो अब even recommend किया जा रहा है कि generally अगर आप सारे embryos को screen करके डालें, even in younger patients with no previous history, their chances of implantation and conception are much, much higher. Time-lapse imaging, another excellent technique to have inside the lab. Basically, इसमें होता ये है कि these are specialized incubators जिनके अंदर cameras लगे होते हैं. आप individually oocytes or embryos को after fertilization इनमें रख देते हैं, and then you don't need to take them out of the incubator to see whether the fertilization has taken place, whether how the embryo development is going, and which embryo to choose basically before doing the transfer. So it's kind of a non-invasive method to choose the best embryo for embryo transfer. An excellent technique to have. इसका advantage ये होता है कि इसमें in a normal embryology lab where there's no time-lapse imaging, होता ये है कि multiple times we have to take out the embryos from the incubator under the microscope to see कि क्या उनकी fertilization हो गई है, उनकी development कैसी हो रही है, और further उनकी grading करने के लिए. So at least 3 to 4 times an embryo is taken out of the incubator in 3 to 5 days जितनी देर वो lab में रहते हैं before we do the transfer. So there's unnecessary exposure to the embryo, to this temperature variation and other oxidative stress भी मिलता है उनको, और basically exposed to environment, which is not good. So with time-lapse imaging, everything is done inside the incubator. So definitely, and all the stages of the embryo development are recorded, even if you're not in the lab. आपको वो record हो रहा है. You can come in the morning and just go through the video and see case embryo की division कैसे हुई है, and it's a very useful tool to have. Now, metabolomics. This is the most recent technique which has come up. अभी routine में ये use नहीं की जा रही, and the concept behind it कि as the embryo develops, obviously there is uptake of certain things and then there is excretion of certain things. There is a glycolysis cycle, there's a citric acid cycle, then amino acids are taken up, oxygen is taken up at different stages, and at the same time they're excreted. So if you use the media in which these embryos are developed, by checking out the media, we can actually find out the quality of the embryo. So without even touching the embryo itself, only the media, from the media we can get this information in which we would know कि ये embryo की development अच्छी हो रही है नहीं हो रही, and this is an excellent tool to have, which will help us to choose the best embryo for transfer. So basically होता ये है कि from egg retrieval day 0 to day 1, it's the maternal genome which is in activation, and the oocyte and then the embryo goes through a TCA cycle, which is the Krebs cycle or the citric acid cycle. As we approach to day 4, the embryo starts compacting and the embryonic genome is activated. And from there on, the embryonic genome is activated and the embryo undergoes a glycolysis cycle. So this known information ko leke, when we check the media in which the embryo has been developing, we can actually tell the morphology of the embryo accurately and select the best quality embryo. So an excellent useful technique. और इसका सबसे बड़ा advantage ये है कि जो आप physically जो आप assess कर रहे हो embryo से, उससे बहुत बेहतर assessment metabolomics के through हो जाती है. And here's a study जिसमें show हो रहा है, ये जो आप blue वाला देख रहे हैं, these are metabolomics results, and grey wala are the normal morphologically जिस तरह हम check करते हैं. So accuracy of the best quality embryo obviously is much higher when it comes to metabolomics as compared to the normal routine morphological assessment techniques that we are used. Definitely this is the future. So in the end, I'll just touch on endometrial receptivity analysis or assessment. This is again a good tool to use in your ART clinic, especially in those patients who've had previous IVF failure or implantation failure. In those patients in which you had excellent embryos, you've done the transfer, a good blastocyst, but the patient did not conceive. इस टेस्ट के अंदर होता ये है कि we prepare the patient for a frozen embryo transfer cycle And at the time जब हम normally transfer करते हैं, उससे पहले around day 14, 15 के ऊपर जाके we do an endometrial biopsy and we test it. We test it. उस टेस्ट के अंदर हमें ये पता लग जाता है कि एग्जैक्ट विंडो ऑफ इम्प्लांटेशन ऑफ दिस पर्टिकुलर पेशेंट क्या है, क्योंकि we all know that window of implantation, it varies from person to person. It depends on multiple factors, cycle length and everything, and it varies from person to person. So with this excellent tool, by doing an endometrial biopsy, you actually find out the exact window of implantation. And then in the next cycle, when you transfer your embryos according to that window of that receptivity window or window of implantation ke mutabik, obviously the results are much higher. We are doing it, although हमारा sample size अभी बहुत बड़ा नहीं है, maybe 25-30 patients we've done till now, but we've had अभी तक हमारे results are as high as 70%, 67 to 70% हमारे पास implantation वो clinical pregnancy rate मिला है. So I've become a big fan of this, and especially those patients जिनका failure हो चुका होता है, yeah, who just want even in the first attempt to increase the chances of success. If you use PGT and you use ERA with it, definitely you'll have excellent results with that. Future of ART, the way things are evolving, obviously time is there जब कोई ना sperm होगा, ना male होगा, ना coitus चाहिए होगा for reproduction. There'll be literally single parent children. Gene manipulation is there, embryonic cloning is there, obviously artificial wombs are there, cloning of adult humans are there. I don't know where do you draw the line. And obviously a lot of people would want to choose the height, the hair and the eye color and even the intelligence for their upcoming child. So completely branded बच्चे जो हैं maybe आपको मिल रहे हों. Obviously a lot of moral and ethical concerns are around these things, but this is the way things are going, and it has to be heavily regulated. However, this is the future of ART and the world. This is my team. We are a big team at Life. Every individual plays an integral role in this team, and like just like Dr. Yusuf said, without a good team, obviously brick and mortar don't get you live babies. A good team gets you live babies. Thank you so much.
Thank you so much, Dr. Harun, for a very enlightened discussion. I feel we're all wiser today about recent advances in ART. Before I go on, could you sharing your screen, Dr. Harun, so I can. So before I go on, there's an announcement for all the participants that if they wish to get a certificate from KZ, they need to share their names, phone numbers, and the area they're from, so that the team can get in touch with them and make sure that they get the certificates. So now we move on. My next speaker is Professor Muhammad Tayyab. Yeah, he's the principal of Amiruddin Medical College, former head of department, Gynae Unit 3, Jinnah Hospital. Every degree that we know of in OBGYN and others has been done by Sir. He was the best graduate of Nishtar Medical College in 1983. He's been associated with Life for many years, since 20 years since he returned from UK. He's the vice president of Society of Obs and Gynecology, best university teacher, no doubt, of the year, and he's also the sitting counselor of CPSP right now. Over to you, sir. He'll be speaking to us about management of polycystic ovaries. So.
Assalamu alaikum. Can you hear me?
Yes, sir. Yes, sir. Loud and clear.
Okay, excellent. Right. Thank you very much, Life Center, and thank you very much, KZ, for arranging this opportunity in COVID days of us getting together. One of the disadvantages of the COVID season or COVID era, other than very sad illnesses and very sad loss of precious lives, has also been this experience of not getting to see each other face to face and interact with each other face to face. And that has taken away the punch and the flair out of our gatherings and meetings. I always was a great believer that whenever you are delivering a talk anywhere or on any forum, a lot of the talk is directed by the body language of the audience who is listening to you. Unfortunately, that is no longer happening. So I was just noticing that we have nearly 200, 180 to 190 participants throughout the forum today. But I'm not exactly sure what each one of the 190 people are thinking right now. So that's a real disadvantage. So I think all it becomes at the end of the day for a talk on Zoom is a monologue and hoping for some people to get interested with time. Great talks by Professor Yusuf on endoscopy, and we all know what a great surgeon he has, mashallah, become with endoscopy. And also a great update from Harun Latif. And Harun, thank you. I learned a few things myself today, and wonderful of you to bring us up to date. I was given the task of talking to you about something very basic and very simple, which is PCO and PCOS. And I can promise you that it is so common in our country that I cannot remember perhaps even a single clinic. I returned to Pakistan as a consultant in 1996. So quarter of a century, I've been now working as a consultant. Before that, I was obviously in my training, and for a number of years I was in UK, but since 95, so in quarter of a century, I really cannot remember many clinics where I can safely say that I have not seen a case of PCO. I think I see one or more than one almost every day. So I'll just try to share the screen here and see if it works for you. Right. Can you see the screen?
Yes, sir.
Okay, good. So I'm going to talk over the next 25 minutes or so and try to just bring us all up to date what I have found in the literature or what I talk about. Because like I said, all of us, we see these patients so much and so often that this is probably the commonest thing we see in terms of gynecology. Right, until about 2 decades ago, and that is what even during our training and when I appeared in my FCPS, which was now almost 3 decades ago, people used to talk about PCOS1 and PCOS2. And for PCOS1, you had to have an ultrasound appearance of polycystic ovaries. And that was this one difference between United Kingdom and United States, which caused this immense transatlantic divide on the opinion of what PCOS was. And that all changed in 2003, which we'll talk about in a minute. Also, there has always been a debate on whether this is a polygenic or multifactorial inheritance. And we also know that the symptoms of PCO are neither consistent in terms of temporally, like in time frame, nor consistent from one person to another. And classically, it's lifelong, and features in an individual may change over time. We all are aware, and like I mentioned at the very beginning, that this is the commonest reproductive disorder or the commonest endocrine abnormality in women. But we also need to remember the difference between PCO and PCOS, because not only lay public, but a lot of physicians tend to use them interchangeably, and that is not the case. PCO may merely be referring to the look of a polycystic, a single or both ovaries on the ultrasound scan, whereas PCOS is the actual syndrome where there may be symptoms as well as signs, as well as its implications. So if you look at the data from the United Kingdom, from the Asian subset of populations, you will find that up to 33% of Asian ladies may actually have PCO. And when we say Asians, that means us, like our daughters and our sisters from the subcontinents, particularly South Asia. As you'll see in the end of the slide, it's earlier, as well as it's more severe in the South Asian. So this whole belt of Pakistan, India, and Bangladesh, we know that PCO is more severe and it's of earlier onset, but not all of them actually go on to develop PCOS as long as they're under supervision, or sometimes spontaneously they have pregnancies and they have babies and nothing goes wrong. But if you just do a incidental ultrasound, you'll find that a lady can have a PCO. So it is suggested that it's a familial disorder, which is inherited as a complex genetic trait. Now, this is what changed the controversy when in 2003, the two main reproductive bodies of the world, which is the European Society of Human Reproduction and Endocrinology, as well as the American Society of Reproductive Medicine, ASRM. When they got together, in 2003, they got together in the beautiful city of Rotterdam in the Netherlands or Holland, where they became to a consensus. And from 2003, for the next 4 or 5 years, because it was just in the journals, a lot of people did not adopt this particular definition. But in the end of that decade, before 2010, it came in all the textbooks, and now it has been around for, as you can see, 18 years, because 2021 is around the corner. Now we know that you need to have any two, a minimum two. You can have all three, but any two of the above the criteria which will label the person as PCO. Evidence of hyperandrogenism, clinical and or biochemical in the absence of non-classical adrenal hyperplasia, as long as you are certain that that's not the case. Secondly, oligo-ovulation or anovulation or evidence of that. And thirdly, ultrasound appearance of polycystic ovaries, say more than 12 follicles and of 2 to 9 millimeters, or volume of the ovary if that's higher. So any two of the three, and this is now an established definition. This is something which is adopted by all nations, and everybody knows about it now. We sometimes overlook the differential diagnosis. It's very easy in Pakistan to say, oh, because PCO is so common or PCOS is so common, it can be nothing else. But this slide is just a little reminder for us to say, okay, it can be something else. It can be adult onset congenital adrenal hyperplasia. And unless we do the hormonal test for that, we would not know. Cushing syndrome, androgen secreting tumor of the ovary, hypothalamic dysfunction, hyperprolactinemia, occasionally ovarian failure may masquerade like that, or thyroid dysfunction. We just need to remember that there may be a differential diagnosis for that. Now, the provisos, in addition to labeling a patient for PCO, is that we need to see evidence. If there is androgen excess, then we need to see evidence of clinical androgen excess, like hirsutism or partial baldness. It's not applicable if a patient is on oral contraceptive pill and you do a scan. If you find a dominant follicle, it is useful to do a rescan a few days later to ensure what's going on. And certainly when I was a medical student, I was taught that we were only aware of PCO as Steen-Leventhal syndrome, which was described in 1934 by two gentlemen, Steen and Leventhal. And we always thought that, oh, PCOS is something so dramatic that it must look like with Cushing-White features, and in which you've got a high LH or a disturbed LH-FSH ratio. I still remember appearing in my FCPS exam, remembering this. Okay, I'll have to say this, high LH or altered LH-FSH ratio. It is not applicable now. It's not applicable. Similarly, it was a classic appearance. Now I'll probably show you the photograph of that, of follicles appearing in the periphery of the ovary, which was called the necklace appearance. That ovaries in the ovary on the periphery, you've got this beautifully lined up along the side follicles, which are like a necklace. It's no longer necessary. It's not applicable anymore. You can have these follicles scattered all over the ovary, and that is fine also. And also, if you got to see two ovaries and you find the PCO appearance in one ovary, it is sufficient to diagnose it and sufficient to label it. You don't necessarily have to have both ovaries affected. This is the picture that I copied from David Lewsley's book, Evidence-Based, in which I thought was beautifully describing something that, okay, because the problem of the presence of PCO and the presence of PCOS can actually be on a spectrum. This actually tells us that on the one end of the spectrum, you see a lady who is ovulating. She's got no dermatological symptoms, and she's got polycystic ovaries. You add to that her genetic predisposition. You add to that her lifestyle. She's a couch potato, watches a lot of Netflix and survives only on KFC and McDonald's. And you add to that a higher BMI. And these ladies, if they put on a lot of weight, because there is an association You find them slowly drifting towards the other end of the spectrum with menstrual irregularities, with hirsutism, with acne, with insulin resistance, and possibly polycystic ovaries still persisting. Okay, so we know that the characteristic PCO is going to develop over a length of time. It develops when a chronic anovulatory state is persisting for a sufficient length of time. We know that PCO results from a functional derangement. We don't find a specific central or local defect in that. Nothing diagnosed to say that. We know that insulin resistance and hyperinsulinemia does participate in ovarian dysfunction in most of the cases. But the interesting thing, and I mentioned this before as well, that insulin resistance is greater and is earlier in us, in South Asians, the female counterparts of us. Well, how does it develop? We know that there is a complex interaction between environmental factors like diet and exercise and multiple genetic factors, as you've seen on that figure from David Lewsley. And then ovarian dysfunction with the more ovarian androgen production, the milieu of the ovary is such that it starts to make more androgens. And not in all patients, in some of them, hypothalamic dysfunction with high LH that can stimulate androgens by theca cells, and we're aware of that. Now, the last part of this slide is interesting, and this is data from a Green Top guideline number 33. And this is new edition that has come in 2014, and it's still valid. And this is on long-term consequences of polycystic ovary, ovarian syndrome. It says insulin resistance in obese PCO is present in 20 to 40%, and in lean PCOs is 10 to 15%. So if anybody goes thinking that the underlying mechanism in all cases is insulin resistance, well, that is not true. As you can see, in more than 50% cases, there is no insulin resistance. And obviously there's so much, that is why PCOS is still something of a dilemma, and there are international conferences on PCO as a topic. What we do know is that because there is a relationship with insulin resistance, up to 35% of PCOS have got impaired glucose tolerance. And 1 in 10 patients of PCOS also have type 2 diabetes mellitus, and they're going to go on to develop it later on. What insulin does do, how does it act? Especially in obese people, it potentiates the action of luteinized hormone, and they both act synergistically to stimulate androgens from the ovaries. The other thing that the insulin does is that insulin as well as androgens, they lower the sex hormone binding globulin, and therefore they free the androgen rise. They worsen the insulin resistance. So this is a vicious cycle which multiplies, especially if the patient is gaining weight. We're aware of increasing insulin resistance, and we are aware of the potentiating action of insulin. One other thing, and I see this a lot, and I think because nowadays every person has got access to a smartphone, is on Google all the time. We see this a lot, that a lot of patients come and say, कि वो डॉक्टर साहब देखे ना, वो जब से मेरा पीसीओ हुआ है मैं तब से मोटी हो गई हूँ, मेरा तो कोई कसूर नहीं ना इसके अंदर. And it's very difficult to tell people that PCO itself, the appearance of polycystic ovary does not make anybody obese. It's your eating habits that make you obese. Maybe it's your genetic tendency of a BMI like that you're probably going to put on more than the others. But PCO as a diagnostic criteria does not turn into obesity. And the only thing that you can do to look after yourself if you have been diagnosed of having a potential PCO is to avoid PCOS by keeping your BMI down, as we have seen in that figure. Because we know that only half the patients of PCOS are overweight. It's just an association. It's not a diagnostic criteria. Right. I don't know how easy it will be to explain this on slide on Zoom, but this is just one of a graphical description of how peripheral insulin resistance turns by compensatory hyperinsulinemia acts on the ovary to produce higher androgens. It's just a figure to explain that, as I've already said. We don't know about as far as the hyperandrogenism and anovulation is concerned, that there is dysregulation of CYP17 androgen forming enzymes in the ovaries and as well as the adrenals, because these are the sources of androgens. The degree of hirsutism we know is variable. We know that that varies from one individual to another. And a lot of that is dependent on the activity of 5-alpha reductase in the skin, which determines the degree of hirsutism. We know that the 4 active compartments of making both male and female hormones are ovary, adrenals, the peripheral skin, especially in older age women, and the hypothalamus pituitary. And DHAS is higher in a few patients, up to 50% patients of PCOS. And that's also interesting, all this coming from the adrenals. This is just a basic biochemistry slide to remind us how from a cholesterol molecule, the various enzymes that work to produce all the female hormones. And I'll not go into details of that. There's a lot of theory here. Clinical features of PCO, which patients present to us with sometimes, and we are all aware of that because we see them a lot, other than their presentation of infertility, is hirsutism, obesity, menstrual cycle disturbances, particularly in terms of oligomenorrhea, acne, oily skin, seborrhea alopecia, and some cases, a few cases showing acanthosis nigricans. This is just a slide of Ferryman-Galway score. I'm not sure how many of my colleagues use this often. I don't think we as gynecologists use that often, but we do know that if a patient is under care of dermatologists, sometimes they are using this to quantify what the score Ferryman-Galway is. You must have noticed that a lot of these PCO patients sometimes are moving between specialists. They have seen dermatologists. I see some patients who already had like 5, 6 or laser sessions already when they come to me. So yeah, so they move between physicians looking for the person who is actually going to look after them and cure it, which sometimes is not possible. These are just 2 descriptions of Ferryman-Galway, and you can choose and pick one and keep one for reference. So how do we make a diagnosis? Obviously, history is very important in all, like in any clinical scenario. Obviously, history is the first thing which you want to go into detail, asking all the pertinent questions. Physical examination, particularly looking up and for any hirsutism or Cushingoid features. TVS, obviously more reliable than transabdominal scan. A hormonal profile. And looking at ovaries, which may actually not show much in terms of follicles, but may actually show a higher size. And glucose tolerance test, because that can correlate with the risk of CVD. Right, this particular slide is the first slide that actually started to show the peripherally placed follicles, which gave rise to this description of necklace appearance in the ovaries. And obviously that is not considered to be extremely important. As long as you have follicles more than 10 and they are scattered around the stroma, that is fine to label a patient. But this was the original slide. The glucose tolerance test, we're aware that there's a 100-gram one and there's a 75-gram one, but we are aware of the normal parameters, and WHO 75 grams is the one that we use here at Life Center. And we're familiar with that. And that is also the one that is more often recommended than the 100-gram one. Readings are pretty similar for both of them. This is not clinically relevant, but some patients you can find who have got the Saha syndrome. They'll have seborrhea, they have acne, they have hirsutism, they have a little bit of temporal balding, and they have associated PCOS. And similarly, another syndrome, which sometimes you find all 3 things, like you find evidence of insulin resistance, but remember that there are no clinical tests recommended to look for insulin resistance. As I've already mentioned, that 60% of patients will not have insulin resistance. So it will not make a diagnostic criteria for labeling someone PCOS. It's so important to remember. But if you've got these, the combination of all 3 of them, you can call this a Naran syndrome. This particular picture, again, I took it from a beautiful undergraduate book, which I like very much. It's an American textbook called Hacker and Moore, Essential of Obs and Gynae. And this is showing a classic acanthosis nigricans. You've got this little black stripe, particularly prominent in dark-skinned individuals, and you will have that either here in the nape of neck or axilla or under the mammary glands or in the groins. Another thing which sometimes is labeled, and you sometimes find that, is this metabolic syndrome X. And the guideline is if you have 3 out of these 5 criteria, you can confirm the diagnosis. A waist above 35 inches, higher triglycerides, high density lipoproteins, slightly higher readings of blood pressure, and somewhat affected blood glucose fasting. So what hormonal profile would you want to do if you're looking at a potential PCO, and what do we normally do? And the first thing is, obviously we would advise that during periods, unless sometimes candidates ask us, or junior doctors ask, okay, what if somebody has such irregularity of periods that you're not having periods for 5 months or 6 months, and how will you choose the second day of the period? Then I will say, okay, well, just send the level anyways. But otherwise, if somebody is having fairly regular or regularish periods, then during periods, you've got to do LH, FSH, prolactin, testosterone, and estradiol. Mid-luteal progesterone, because of the variation in cycle, that's not necessarily a day 21 progesterone. It will be completely invalid in shorter and longer cycles. So whenever you want to prescribe mid-luteal progesterone to a regular menstruating lady, you say to her, get it done a week before your next expected period, because that will always be mid-luteal, because we know that the luteal phase is constant for 14 minus plus 2 days. And then how you calculate free androgen index by sex hormone binding globulin and testosterone. And if you find hirsutism, then you also want to know, especially if you got significant hirsutism, to look at androstenedione and dehydroepiandrosterone sulfate, which may be of adrenal origin. Right. This was one of the Green Top guidelines, which I've just showed you. This is the older edition, and this is the newer edition. This is from 2014, and it's still valid. And long-term consequences. The reason why I put this slide up is because of the fear in a lot of patients' mind when they're asking, you know, I've done my Google search, and now the only thing I'm going to have is death, and I'm staring into, I'm going to die now because I've got PCO. And sometimes it's so difficult to shake that belief, especially if any doctor, particularly a gynecologist, has you know, scared the living daylights out of that patient, then obviously she's going to come with you with a lot of scare, and that is another important thing. So this is according to the guideline, where you'll see that GDM and type 2 diabetes, these patients either they have a tendency to develop GDM, or they have a tendency to develop type 2 diabetes. And if they're obese, there's likelihood of developing sleep apnea. There is a higher propensity of developing cardiovascular disease, which again is also compounded by obesity. Some of these, because of obesity, may have this problem with the self-image, and they may have associated depression and or anxiety. And the best person to judge that is the gynecologist, because of the close association with your patient. And lastly, not ovarian cancer and not vulval cancer and not cervical cancer, but there is a question mark on endometrial cancer. And that is why it's important to keep an eye on patients who've got prolonged periods of amenorrhea, and patient who is nulliparous, because you want to be sure that what we can do about that. So how can we reduce these long-term effects? One obviously is to ensure that you do a 2-hour 75-gram OGTT. And in patients who are slightly obese, or who have this propensity of obesity or higher body mass index, it is recommended to do an annual screening with OGTT, so you can pick up any earlier onset of type 2 diabetes, mellitus, or impaired tolerance. The cardiovascular disease risk factors have not been substantiated in relationship with polycystic ovary, in the sense that we don't have a set criteria to say, okay, these are the patients who will develop CVD. So it's important to look at individual CVD risk factors, the obesity, the lipid profile, any medication, any family history, and so on and so forth. Exercise and weight control are important in terms of reducing long-term effects. And lastly, as I mentioned, ensuring that the patient who has got oligomenorrhea, particularly if she's nulliparous, to ensure bleeds every 3 to 4 months, and keep the endometrial thickness below 7 mm to reduce her chances of developing hyperplasia, or reduce her chances of developing later malignancy. So if you look at some management principles, it's important that especially with patients who are overweight or who are obese, to reduce weight, because if a patient is able to reduce 10% of weight loss, what does that mean? 90 kg patient going down to 81. that is actual reduction of about 30% of visceral fat, because android obesity, like waist circumference, higher waist circumference, is more risky than the other kind of obesity. Diet, looking at diet and exercise. And exercise now, as you're all aware, is heavily recommended even in pregnancy for half an hour every day for 5 days a week at least. But we do know that by reduction of, because I do not think that clinicians and gynecologists in our country emphasize weight loss sufficiently. I feel that we usually either overlook it or don't emphasize it that important. But what does the science say? The science says that loss of even 10% of weight significantly improves hormone profile, ovulation rates, and spontaneous pregnancy rates. That is what science says. This is a table from 2 decades ago, but this is in current vogue. This is what is accepted now of what we know about BMI. And we know that a normal BMI is up to 24.9. Obesity begins at 30. And then we see a lot of patients with morbid obesity, which is class 3, 40 plus. We see them a lot in Pakistan. So I think we need to remember, first of all, before looking at this slide, is that exercise and diet are the cornerstone. Medication is not the cornerstone of reducing obesity. But if you have to give medication, these are the two medicines that are currently in vogue. One is called orlistat. And the second, which is much less used now because it's centrally action, is sibutramine, because it may increase blood pressure. But orlistat does cause peripheral action, pancreatic lipase inhibitor, and it prevents absorption of 30% or 1/3 of the dietary fat. This is just a slide that I picked up. I looked at the Pakistan Pharma Guide to see, obviously this is not a complete list. I apologize to anybody's feelings if they don't find their favorite medicine not present here. But just to mention to you that these are the various medications that are available. Like I said, orlistat is more commonly used around the world and in Pakistan as well. A comment on bariatric surgery. We now in Lahore at least have got, I think about at least five very good bariatric surgeons, laparoscopically doing gastric sleeve resections. Instead of gastric banding is not very popular now, but gastric sleeve resections. We have at least 2 working at Hamid Latif Hospital, and we see a lot of patients whom they treat. This is the treatment option for morbid obesity, BMI above 40, morbid, or BMI above 35, but with comorbid conditions. But the important thing is, if you bring a patient for laparoscopic gastric sleeve resection who is weighing 140 kg, for example, you have to ensure that they do not become pregnant for a minimum of 6 months after that or 10 months after that, because they are dropping their weight so rapidly that if they conceive in that window, then during pregnancy, they will keep dropping weight and they will really feel unwell because they're dropping weight, and in pregnancy, you're not allowed to drop weight. We don't advise weight losses in pregnancy. Even we are aware that even with obese patients, we say, okay, an average weight gain of 6 kilograms in pregnancy is allowed. So you have to ensure that if you've done gastric sleeve resection, then they don't become pregnant for at least 6 months. Because in the first year, a lot of patients will drop 50 kilograms or 60 kilograms and say they need to come back to that baseline and then try to conceive after that. What about anovulation in infertility? Well, weight loss, I've already mentioned in the obese PCO. The medication that are used, it's clomiphene citrate and tamoxifen, which according to one journal, Human Reproduction in 2005, was shown to be equally effective, but we are all aware that hardly anybody uses tamoxifen. We use clomiphene citrate. The problem with gonadotrophins, if we are not skilled with that, if you're not skilled on using gonadotrophins, if you're not, we're just doing it from a clinic and we're not in an IVF setting, then the problem with that is risk of ovarian hyperstimulation syndrome. And if any of my colleagues listening here today has seen even one patient of severe ovarian hyperstimulation syndrome, you will never forget that patient in terms of the seriousness of the problem and in terms of the stress on the physician. We have seen many because we work in IVF center, and you have to be extremely careful when you overstimulate ovaries. GnRH agonist pump is not recommended for these people. Clomiphene citrate, as you know, time tested, used forever and ever. The mechanism of action is in hypothalamus. It binds to and blocks estrogen receptors. This releases pituitary from negative feedback. This causes increase in GnRH pulse amplitude, and so increase in FSH, leading to follicular growth. One of the things that we all see that is this clomiphene resistance in obese PCOS, and we are aware of that. The other drug which has become popular over the last decade at least is letrozole and other aromatase inhibitors like anastrozole. They inhibit ovarian aromatase activity, so they decrease in serum estradiol, increase in FSH, and it causes follicular growth. That's the mechanism of action. The advantage that is quoted with the letrozole or anastrozole is that the possibility of twin pregnancy or multifollicular development is reduced. But there have been very few studies head-to-head with clomiphene citrate. And as recently as last year, when we went to ASHRAE conferences in Europe or ASRM in the United States, I have not heard people coming out categorically to say, right, ladies and gentlemen, aromatase inhibitors have replaced clomiphene. No, it has not. No, it has not. So it hasn't. So it is available. You can do that, but it has not replaced it. And in clomiphene resistance, you can use that. Well, risk of OHSS is lesser, and we are aware about that. It's a 2.5 milligram drug, as you're aware, letrozole. It has got no anti-estrogenic effect on cervical mucus. We need more RCTs, obviously, like I said, to make that categoric statement. In some countries, it is not licensed for anovulation, but I think a lot of people are using it now. This is the other paper which came from the Royal College of Obstetricians and Gynecologists, because the other drug which we're very fond of using is metformin. And this was the older edition, and I have with me the newer edition here. This is published in August 2017. Metformin therapy. It used to be called Scientific Advisory, and now it is called Scientific Impact Paper. The title has changed for these advisory papers. And this was published in 2017, so it's come after 9 years. What does it say? What does it say? Well, it says that what does metformin do, and why do we use it, and why it became popular? It inhibits production of hepatic glucose. It enhances insulin sensitivity at a cellular level, and it has effect on ovarian function. Now, according to this guideline or this paper, it has got no role in weight loss. I really enjoy seeing a lot of prescriptions coming from some gynecologists and occasionally from some endocrinologists, and patient has been told that you start taking it because your 120 kg is going to become 60 kg if you start taking metformin. Well, this is what it is. I mean, I've not written this down. It is coming from this source. It has got no role in inducting weight loss. It is safe to give in pregnancy now. When I was a medical student, I used to read, no, we cannot give any oral hypoglycemics. And then when I became a postgraduate, I learned, okay, we can give it because there are no teratogenic effects. But the problem with that is it does not control blood sugar as well as insulin, so we should keep insulin. But now over the last decade or so, we know that there's a World Health Organization guidelines and FIGO guidelines, and we use metformin a lot in pregnancy, especially for early GDMs before going on to insulin. The other thing which was debated initially was that is metformin a first-line treatment of choice in PCOS in terms of inducing fertility treatments? No, on current evidence, it is not a first-line treatment of choice, but it does remain a second line. So if you've got clomiphene resistance, or if you've got an obese patient you want to put on clomiphene, then metformin is probably a good choice to add with it, especially in Asian populations, which is ours. Right. I thought I'll add that because this was not in the previous edition, but this is present in this edition, metformin and IVF. I thought this was interesting because what they have done now recently is they've done a Cochrane review of 816 women in 9 studies comparing metformin with the placebo or no treatment before and during ART. And they're saying, okay, if you're using it, the clinical pregnancy rates are higher. The only proviso, I've not written it down here, but is that although the clinical pregnancy rate is higher, the live birth baby rate drops a little bit. So maybe the power of the study is a little bit affected. So we need to know a little bit more. And maybe in half a decade or so, we'll find out a bit more. And also, we know that the ovarian hyperstimulation is lesser when an agonist protocol is used. And as you saw Harun mentioning half an hour ago, that now we're not using agonist, the long-acting protocol that often. We're using antagonist protocol because it is patient-friendly. You don't have to give injections for 14 days prior to beginning treatment, because we give antagonist, a shorter protocol, the chance of OHSS is lesser anyway. So maybe that aspect of, we don't know what is the role with antagonist. If we add metformin with antagonist, we probably know in a couple of years' time. This is also very interesting, role of ovarian drilling. And what has happened in Pakistan also is that as more and more people have started to learn laparoscopic surgery, maybe they're not as good as Yusuf Latif yet, but they've started to use laparoscopic surgery more often. So what is happening? A lot of people have started to think, because I can do it, I should do it in PCOS. Now, look at the Green Top guidelines, November 2014, which is long-term consequences. Bilateral ovarian drilling, what does it do? It causes thermal damage and it releases intra-ovarian inflammatory cytokines. It changes the local hormonal milieu and reduces the androgens by about 50%, but the insulin sensitivity in those half the patients of the PCOS, it remains unchanged. Bilateral ovarian drilling will have no effect on hirsutism that has already occurred. Particularly, it will have no effect on obesity. So what do you do then? Well, it is reserved for selected women with anovulatory infertility and a normal BMI. And one thing we must remember, and we need to be very careful about that, is that ovarian drilling may actually affect the reproductive capacities of the ovaries in the future. So you don't want to destroy ovaries. And I've seen, I think 4 or 5 patients still now in Pakistan in whom the complaint was that, look, we took a young patient to Dr. A and B, and that doctor did an ovarian drilling, and he made so many punctures in the ovary, and so much thermal damage took place. Now the ovaries have packed up, the FSH has gone up, and there's infertility. And you don't want to hear that when you're treating somebody for fertility. So the indications of ovarian drilling, well, on anovulatory PCOS, clomiphene resistance, or patients who have not responded to clomiphene, persisting high LH along with that, then repeated over response. You've seen these patients who have been given only, say, 50 milligrams of clomiphene citrate, and you find that she's just developed a cyst, and that cyst is persisting for 3 months, and now you don't know what to do about that. You say, okay, well, let's do an ovarian drilling and see if we can reduce the chance, the usage of clomiphene citrate. On non-compliant patients who cannot come for regular scans, and we know that patients who have got marked obesity and marked hyperandrogenism and long-term infertility, they are more resistant to this treatment of ovarian drilling, and therefore they may not be good candidates for this modality of treatment. What about patients who have got menstrual irregularity and hirsutism and not necessarily looking for fertility? Well, we know about weight reduction. We know about any combined oral contraceptive pills. I haven't made a list of the OCPs which are available in Pakistan, but Diane is freely available, and Yasmin is not available, but Yaz is available. What does that do? What does that do in hirsutism? Oral contraceptive pill, well, the progestin component suppresses the luteinizing hormone, and estrogen increases hepatic production of sex hormone binding globulin. Estrogen suppresses 5-alpha reductase, and it reduces androgens as well. The success rate is variable. We are all aware of what we can do for hirsutism and all these cosmetic, but I will just quickly mention here that there are many laser clinics in Lahore, and maybe in other countries, other cities as well of Pakistan. And the majority of them are just there to make money. Laser is not the final treatment for all of these patients. And it's very sad when people do that. So in summary, just some take-home messages. We now should all be absolutely clear on who to label a PCO and who to label a PCOS, and to remember the ASHRAE ASRM definition, 2 out of 3 criteria. We need to remember the heterogeneity of symptoms and signs. Sometimes it's very difficult to convince patients. He says, doctor, in 2017, I had PCO, And then I went to Dr. Fulan in Hafizabad, and she gave me treatment for 3 months, and my PCO has been cured. So I'm very happy now. And it's very demoralizing when I say to her that maybe in 6 months' time you do another scan and the PCO has come back. So sometimes you see it and sometimes you don't. It doesn't necessarily mean you got to live with it. I've talked at length about polycystic ovary not being PCOS. I've talked about insulin resistance being a key factor, but not in all the cases. And remembering that weight loss is the cornerstone of therapy in obese PCO. Finally, high LH and LH-FSH ratios in peripheral follicles on scan are not essential to make a diagnosis. We need to remember the long-term effects and due to unopposed estrogen. For God's sake, people who do this research on computers and come and tell you 10 other things that are going to go wrong with them, you tell them, look, lady, with due respect to you and your research, you may be looking at websites which are not reliable and therefore only 3 or 4 main risks, and we've mentioned that. Management, obviously, for any lady will depend on whether fertility is desired or not desired. Ovulation induction by metformin or laparoscopic ovarian drilling is on in patients who have got clomiphene resistance and you do not yet want to go towards IVF. Thank you very much.
Thank you very much, sir. It's always a pleasure listening to you and learning from you, and a very informative talk indeed. Thank you, sir. Before we go on, again, a reminder for people to share their numbers and names and areas to get the certificate from KZ Pharma. And now we'll have the question answer session after we're very blessed to have Professor Raj Latif Khan to be here today with us, as I introduced earlier. Now I would request sir to kindly conclude the session, and then we can have the question answer session after that. Over to Professor Raj Latif Khan, sir. Assalamu alaikum.
Bismillah ar-Rahman ar-Rahim. Thank you, Mariam, you look good. And I must compliment and congratulate KZ people for organizing this webinar. It's so unfortunate, as Tayyab mentioned, that we can't have live conferences because of COVID. Nobody was prepared for COVID. It has brought total change in our social, professional environment. And today, we are having this webinar with the courtesy of KZ people, which is a great leap forward in promoting knowledge about 3 different areas. I compliment them for organizing this webinar. I'm told a lot of people are attending it. I wish there could be more. First of all, Professor Yusuf Latif spoke about endoscopic surgery. You know, laparoscopy diagnostic was introduced in Pakistan in 1974, way back, nearly 45 years ago. But unfortunately, we did not keep up with the pace of endoscopy or endoscopic surgery the way our neighbors have done it. And believe it, in Pakistan, this endoscopic surgery was helped by an Indian, and who came over to teach us, whereas we were perhaps leader amongst them. And anyway, now endoscopy is catching up, and there are few centers who are doing good job. And Yusuf is also one of them, and his team. I hope they continue to train more people, because this is the need of the country and our patients. And Yusuf, do more of it and train more people so that this is available like Lab Coli at every town, every center. Then Harun came. I'm so glad that 2 of my sons are keeping pace with the modern technology, the theme of treating patients. And Harun spoke about latest developments in ART treatment. And I'm sure there are, although very few centers, but all these centers are providing services on the modern lines which Harun mentioned. And it's so hard to keep up with ART technology internationally, but we are with it. Inshallah, our results will continue to improve as we adopt the latest methods and technologies although it's expensive to get PGT and other methods, ERA and metabolomics, but we must invest in that to get satisfactory results for our patients. Then came the best speaker, Professor Tayyab. There's no doubt. The way he covers the subject, it's like bird's eye view of whole PCO. Etiology, pathology, and clinical features, management, all that. He did it so beautifully in such a short time. And I must compliment him for that, for giving up-to-date, latest knowledge about PCO. And, but there are 2 or 3 things which I would like to say. One, young girls, unmarried girls are brought to the gynecologist because mother is worried for irregularity of menses, overweight, hirsutism, and things like that. And they have sleepless nights. After listening to Tayyab's lecture, most of PCO patients, maybe they don't even need any help or treatment, or those who need some help medically that is available. So satisfy them. Although in Pakistan, as Tayyab mentioned, that internationally 33%, Asian countries even higher, maybe 40%. 40% girls are PCO or PCOS, but they can be helped. So our role is as a gynecologist, also as a social worker, to reassure them that mother is worried about marriage or subsequently fertility, but they can all be helped with modern treatment. And secondly, soon after marriage, fertility can also be dealt, as Tayyab mentioned, by clomiphene citrate or other methods of treatment. And which a warning which he gave to all of us, that PCOS patients should not be just let go after having 1 child or 2 child. They need long follow-up, but because they are long-term side effects of PCOS patients. And so please keep follow-up of all your PCO patients so that they do not develop complications later in life, which could be life-threatening. Once again, I compliment all the 3 speakers. They did a beautiful job and covered their subject very, very well. And last of all, again, compliments to KZ for doing it and Dr. Mariam. Without Dr. Mariam, I don't know what we would be doing. It is her interest in promoting these webinars and educational activities, which is keeping the reputation and the interest of medical education at Hamid Latif Hospital. Thank you, Mariam, and good to see you, but at least on the screen. Thank you once again.
Thank you so much, sir, for your kind comments and your valuable conclusion. I'm so grateful, sir, for your time. Now we'll move on to the question answer session. And to start, I'll start with Dr. Yusuf. The first question from you is by one of the participants was, what is the role of DNC in repeated implantation failure?
Role of DNC. I think scientifically proven I don't think so that there is any role for DNC for repeated implantation failure, even for an IVF or for a normal cycle, because in DNC you can't actually see anything or you can't get it, and the maximum you get some endometrium and you send it to lab and they'll give you a report of either secretory phase endometrium, and that's about it. It normally doesn't help. So hysteroscopy is the gold standard. We do that in life after we have good embryos and they fail to implant after 2 cycles. Then we do this. We don't do it in the first line, but as a second line. And while doing that, if there's small synechies or anything else, then we kind of take that care of with the help of cold scissors. And the last part, there was a time when they were saying endometrium shaving. or what they say, if you damage some of the part of the endometrium in the uterus, as a result, there's a lot of blood supply increases, and as a result of this, the implantation rate may be increased, but it hasn't picked up as a gold standard till now. People are working on it, so that is might of a future, but I don't think so. DNC has kind of any role for repeated endometrial repeated failures, either in IVF or abortions.
Thank you, sir. Thank you for that answer. My next question is from Professor Mohammed Tayyib. So there's a very important question. In fact, I have that question too. How to manage non-obese PCO patients who are unmarried with oligomenorrhea? Dr. Tayyib?
I think you need to repeat the question.
Yeah, sorry. So this is for Dr. Tayyib. There was a question, a very important question for all clinicians. We all struggle with this. How to manage unmarried girls with oligomenorrhea who are lean, thin? So could you please
Sir, आप
unmute?
unmute करें.
My apologies. Okay. Yeah. Yeah, thank you. You're absolutely right. We cannot tell thin, lean girls to reduce weight, although I have seen 2 or 3 patients in my clinic who weighed 50 kilograms and they were asked to shed 5 to 6 kg more because of oligomenorrhea. We don't do that, obviously. One of the things which we can give and try giving if they're worried about oligomenorrhea is to give an oral contraceptive pill, explaining to, because they're usually brought by their mothers, explaining to the mothers that the only thing that this is going to do is to give them 6 cycles of withdrawal bleed. And if they've got hirsutism, then we can, instead of a routine oral contraceptive pill, we can give Diane, or a little less effective is Yaz. They're both available in Pakistan. But if the oligomenorrhea is erratic, for example, sometimes 6 weeks and sometimes 8 weeks, we do not necessarily have to treat it because it usually settles down with time.
Thank you so much, sir. Thank you for your response. The next question is actually Dr. Haroon Latif. They want to know what are the supplements, good supplements to give because they believe that semen analysis is not very effective and not done properly in many centers. So if somebody with the normal parameters, what would be a good supplement to give them?
Thank you for the question. I think there's no harm in giving supplements to male patients, even if the semen parameters are within normal range, because these are antioxidants and they definitely do play a certain role in improving the semen parameters. Basically, what I do in my practice is I divide these supplements into 2 parts. One for fording patients and one for non-fording patients. Patients who don't have a financial concern and can afford, then the good supplements to give them are L-carnitine or acetyl-carnitine, coenzyme Q10, lycopene. These are the 3 good supplements where they have. These supplements do have a role in helping sperm motility, to a certain extent sperm morphology as well. They may not increase sperm count. So we always remember that वो quality of sperm को तो बेहतर करेंगी, but not the number. The number would not increase by using these supplements. Secondly, for patients who can't afford that much, उनके लिए equally effective supplements हैं, which are basic supplements like vitamin C, like zinc, selenium, things like that, and vitamin E, Evion. There's so many brands which are available. उसमें cost भी कम रहती है और they're also almost equally effective. इनकी जो duration of treatment है is about 3 months to start with. You give the supplements, you wait for 3 months, you repeat a semen sample. If there is improvement, you can continue the treatment for another 3 months. And if there is no improvement after 3 months, then there are certain set of patients who don't really respond at all to these supplements, then there's no point in continuing them. Thank you.
Thank you. Dr. Tayyib, there's another question for you. What is the role of minoanisotol in PCO and infertility? Because a lot of doctors are using it nowadays. So kindly unmute yourself.
Sorry, I said none because there is no evidence, scientific evidence of giving it in a clinical setting. A lot of doctors are using it more and more only because the medical reps are very good at selling it. If there was any evidence, it must have appeared in at least one of the guidelines. So I have not seen it. And I've already mentioned that insulin resistance is present in 10 to 15% of lean PCO and 20 to 40% of obese PCO. So there is no insulin resistance in more than 60% of patients anyways. And people are now researching that and what to find. So I really don't know.
Thank you, sir. Thank you. In the interest of time, we'll have the last question because most of the questions will be answered later on. This is for Dr. Yusuf. Is there a role of passing a balloon after Escherman syndrome adhesions breakage? And for how many days do we keep in the balloon? So please unmute yourself.
When we started doing these cystoscopic resections and for Escherman, then we used to do it for about 48 to 72 hours. But as the literature goes on, there is no kind of guidelines to kind of do that. There was a time when we used to do it, put in just a copper T with taking out the copper and just putting that whitish plastic probably, just to make sure the adhesion doesn't work. But in the end, the best thing which, if you can afford it, is this hyaluronic acid in the uterine cavity, which works best. If you don't have it and if there's no bleeding, then the next best option is to kind of repeat it after about 3 months' time. But I don't think the balloon, copper T, or anything, and any barrier kind of makes it more easier.
Thank you so much, sir. Now we'd like to thank everyone. Thank you so much, especially for the chief guest to be here and spare time for Latif Khan, and obviously the valuable speakers, Professor Mohammad Tayyab, Professor Dr. Yusuf, and Dr. Haroon for very, very very interesting talks and a detailed, elaborate discussion on the topic. And now I'd like to thank especially the participants who took out the time on an afternoon of a working day to hear us out, and we are very, very grateful for your patient listening. And thank you again for the KZ Pharmaceutical for arranging this session and giving us an opportunity to spread the word about ART and laparoscopy. We're very grateful to all of their team. And thank you again for being here, everyone, and you stay safe. And if there are any questions further, you can send us through KZ. And please, if you've not added your number and name, please do that right now, because the team will get in touch with you for the certificates. Thank you again, and stay safe and stay blessed. Allah Hafiz.